So hello, Tabit, you made it. I was just communicating with you, so it's nice to see you. Sue, hello, and Kelsey and Cindy and Angelina or Angela. Very nice to see you guys. I did put in the link here if you still need it for the workbook. And I'm going to go ahead and hit record. So we are all ready to go. Actually, no, I should get my slides really quick. Stand by. Let's get those slides going. All right. Okay. So let's kick off this EKG challenge. So welcome in, guys, officially to the 3-day EKG challenge. This is night one, and we're excited that you're here.
Recording in progress.
And what we're going to do is we're going to make sure we hit record. So this is saved for you guys. It's recording. Awesome. Okay. So now we're on Facebook too. Perfect timing. So guys, as we're getting started and waiting just 2 more minutes for let a couple more people in, I want to hear a little bit about you. So type in the chat, those of you who are on Zoom, what practice setting do you work in? And are you RNs, PAs, NPs, medics, EKG techs, residents? Maybe type in the chat so we can get to know you a little bit, like what your background is, so we can make this more pertinent to where you work. I see we have Marla or Marcia, yay. Giovanni, hello. NP in clinical research, very interesting. That must be a very relaxing job compared to working in a clinic. I think that's like everyone's dream job. But we're cardiology NP for 8 months. Cindy, yay. Awesome. It's really exciting but scary, right? Really exciting but scary. Anyone else want to share what they do? CNA, perfect. Welcome. NP primary care. Okay, yeah. You are probably very busy, right? And work-life balance. So we're glad you're taking the time to be here with us, considering that. 22 patients a day. Yeah, you're busy. Kelsey is an NP student going for exam and going into palliative. Oh, wow. I'm really glad to hear that because that is such a good service. Wow. You guys are amazing people. So thank you for being here. It is now right on time, so we'll get kicked into the knowledge for the evening. So welcome into the 3-day EKG challenge. My name is Jen Carlquist, and I will be your hostess for the evening. If we're lucky, my co-hostess, Michelle, will be stopping by as well. And this is, of course, my co-pilot all the time is Remy, my EKG reading German Shepherd. He was named after STEMI, of course. So what we're going to do tonight is, first of all, announce the most important awaited thing all night, the Invite a Friend contest winner. Okay, now, what we did was the whole past week, we said, hey, if you invite a friend, we'll keep track on the back end of how many people you invite, and we'll be giving away prizes. And so I want to kind of talk about the winners and the prizes. Now, first of all, I have to say the competition was pretty fierce. Marie and Cheryl were duking it out big time, but Cheryl ultimately came in our winner. So Cheryl, hopefully you're watching. Congratulations. Cheryl, I think, knows the most people of anyone I know. So strong work, Cheryl. Thank you for bringing your friends. We love everybody you bring into our group. But Marie, you won second place. I'll talk about your prize. And KJ won third place. So strong work, KJ. KJ is not only a good group advocate, but also getting on the leaderboard here. And then Komal, who's a longtime group member, got fourth place, which I'll tell you about in a minute. And Kim tried really hard. But thank you for the good effort. We're still going to give prizes to 4 and 5 because you got on the board. So the prizes are as follows. Cheryl, if you want it, you get a one-on-one session with me, which is what we advertised. But I know when you've won this in the past, you've wanted something else. So we can talk offline about that. And then the second prize going to Marie is the RCAT EKG workbook that comes with the badge. So strong work. And KJ, you get a badge, but I think you already have one. So we should talk. You might want something else. But of course, if not, this is coming to you. And then basically the fourth and fifth prize are paintings. So Kamal and Kim, you can tell me which one you want. These are the 2 paintings. And you can tell me which one you pick. And I'll be sending these out to you guys. So congratulations to our winners. We're so, so, so excited. So great job. Okay. So one other thing I want to talk about in housekeeping before we get kicked off is that we also have a scholarship we're going to be giving away. So why would we talk about a scholarship before we even talk about the class? Because here's what the scholarship is. So one person, one lucky person in this class with us the next 3 days is going to win a 30-day completely free scholarship to our paid course that we do on EKGs called the 30-day 30 EKG Challenge. It's just like this, but actually we teach you all the things, not just a little bit of the things, because we have more time. And so you actually get access to everything we've done in the past 3 years recording wise while you're in the group and all the live classes. So I'll talk about that a little bit more as we get through the class, but I did want to incentivize you because the contest starts now to win the scholarship. So here's how this works. This is my dad, my late dad, and this scholarship is in honor of him. And so I'm looking for the person that most likely represents the attributes that he had, which was being kind to others, lifting people up, nurturing, supporting, rooting for the underdog, right? Those are all things that my dad embodied. And so because that's what this community is also based on, we want to see you helping out your fellow colleagues that came with you on this challenge. It could be a complete stranger, but we want to see you rooting them on. If you see someone who's lost, can't find the live, help them find the live. If you see somebody who's like, where's the workbook? And you can find the workbook, send them the workbook. If you can find someone who needs a replay and you can get them the replay, anything you can do. Or if someone takes a chance and guesses on something and you're like, yay, go Lisa, right? Or whatever, that's the kind of stuff I'm looking for. Whoever does the most of that, who is the most kind, the most giving person, I'm going to give you a scholarship. So that's how this works. And you're going to have some stiff competition. I will warn you if you are in the market for the scholarship. KJ, whenever KJ is around, KJ is like the ultimate cheerleader. But KJ did not win last time. So there is room to beat KJ, but I'm going to just put your eyes on KJ. If she's saying something, follow her lead if you want to win the scholarship. Anyway, let's talk about our course and we'll talk a little bit more about introductions. But Marcia, I just read what you bring to the table. Wow. That's cardiology outpatient NP 1 year. Marcia, welcome. You're in the right place. And cath lab RN. So it's perfect. It's a big change though, going from like inside to outside. And we should talk offline more about that because I just made the opposite transition. But anyway, we'll talk about that more later too. So what are we covering tonight? We're going to cover a 10-step system in reading EKGs. We're also going to talk about a normal EKG and how to kind of learn what that looks like so that we can pick out the abnormal things. We're going to talk about on night 2, the conduction of the heart. We'll talk about the waves tonight. And I'm going to share with you my very secret, actually not so secret roadmap that I put together to help you get confident with EKGs. Because the one thing I saw when all of you came in and you answered a question in the intake form, you said a lot of things surrounding, heart blocks, bundle branch blocks, not feeling confident, feeling like an imposter. Somebody said, I've been an NP for years. I still don't know how to read them. And so everybody kind of had, this general theme of not feeling confident and comfortable. And so I applaud you that you're here. Oh, Michelle is here. My co-host has made it. So happy. If she has a chance to come on screen, we'll get her on screen. But basically, I'm going to share with you how to get confident. Okay. I'm going to show you the secret roadmap. But again, it doesn't matter where you start, right? We have people in this group from all walks, literally all walks of professions. And, you've already talked about hopefully you've put in the chat what part of the team you're on, but we believe that everybody, right? Everybody needs to be good at EKGs. And I just want to take my hat off for a second there's an EKG tech that I worked with in an ER. And she actually was smarter than some of the ER physicians on the high-risk EKG findings. She was spotting things that they weren't. And so I believe that she saved some lives. So I do believe that we're all a team, and sometimes if someone misses something, the other person catches it. But that's why we have checks and balances, right? When providers order medicines, nurses need to double check, right? So we all catch each other. But basically, no matter where you are in the spectrum of the healthcare team, we all need to know this stuff. Unless you work derm, and if you work derm, you're probably like living the good life. Anyway, proof of concept. Okay, this was me. You can see here. Okay, this was me when I was maybe 20. And this was one of my first paramedic jobs. This was my great partner, Frank. And I don't know if you look at my face here, if you're like, oh yeah, she looks like she's comfortable at combat with EKGs. No, 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 no. I actually was terrified and literally had very little training, had to train myself. And I was the highest medical authority on scene because he was an EMT, I was paramedic, and we didn't have cell phones back then. Yes, it was a long time ago. And so it really forced me to get comfortable somehow. So I had to make a strategy. So as I as I go back and I look how I got there, that's what I want to share with you because I wasn't always somebody who puts on a 3-day EKG challenge. Okay. I also struggled and I rode the struggle bus for a long time. In fact, it almost broke me to where I didn't want to continue on in paramedic school. Right. So eventually I got some help. I got a mentor, somebody that could teach me, and things were great. And look where I've come, right? From that scared paramedic who was shaking in her boots, didn't even sleep on a 24-hour shift because I was so terrified and I was studying all the time. And now I lecture across the country at conferences and I work, well, until about a month ago, I've always worked ER and cardiology, but now I just do cardiology. And, I now am responsible for reading the EKGs, which is a big responsibility. But I also know, even now with experience, I also know when to ask for help. And that's the key, right? And that's why you all are here, beefing up your knowledge. Hey, KJ, I was just talking about you, how you are the one to beat for the scholarship all the time. And Michelle's here. Michelle, I'm so happy to see you. Michelle, my co-hostess with the Moses. Well, yeah, Michelle, I think you're still in the middle of the ocean, if I'm not mistaken. So thank you for logging on tonight. So we're going to talk about learning EKGs and how does it happen? And also what we're going to cover in this challenge. We're going to talk about what an EKG is, what it can tell you, the normal waves, the heart anatomy and how it corresponds to the EKG. We're also going to talk about the 4 parts of the heart we look at with the EKG electricity. We're going to learn rhythms tomorrow night, which is going to be super fun. And then on the third night, we're going to talk about reciprocal contiguous leads and also a little bit of terminology throughout the whole challenge and talking more about really what normal is. Now, if you continue on in our 30-day EKG challenge later, that's where we start diving into kind of going deeper, right? Where this is just basically scratching the surface and what we're going to teach you tonight, but we actually go into like learning STEMI, semi-mimics. We talk about axis. We talk about high-risk patterns. We talk about the new STEMI equivalents that were just announced in a new article update 2022 and that a lot of people don't know. So we got to start here though, and we got to get you comfortable with the fundamentals so that you know what normal is so you can spot abnormal. So this is where we start tonight, basic waves and rhythms and intervals. We'll talk about that. And also we're going to talk about what the leads look at, what a normal EKG is, a little bit about coronary anatomy, and then later you would go and start learning this, but eventually it would lead to confidence. That's my secret roadmap. And this is an EKG just to kind of break the cycle of introducing ourselves. And basically, I don't think I told you I've been a PA for 17 years now, and prior I was a paramedic for 13 years. So I bring to you different perspectives on the EKG. I'll just say that. Okay, so if anybody is super advanced, and we always have somebody who is in this class, you can spot the abnormality right away. But if you're new, I'm showing you this EKG not to scare you. Well, okay, a little bit to scare you and motivate you, but also to show you the value of the T wave. Okay, so the T wave is priceless. It can tell you about electrolyte abnormalities, for example, hyperkalemia. It can tell you about ischemia. It can tell you a lot of things. And here is the first rule of the night, okay? The T wave must be upright, okay, in all the leads except for AVR and V1. All the rest of the T waves must be upright. So this guy, he's following the rules. This guy's following the rules. This guy's following the rules. But the rest of them, they are wreaking havoc. Look at this one. Look at this one. This one, inverted, inverted, bad. This one shouldn't be upright. Neither should this one. But, and also this one's inverted. But let's go back over to V4. V4 has something super high risk. And I'm going to tell you a story about this gentleman to highlight the value of what I'm going to teach you tonight. Okay. This patient has what's called a biphasic T wave. So not only does the direction, but the shape matter. Biphasic is a shape, but the size matters. So basically the T wave is the star of the show, pretty much second to the ST segment, which we'll show you. Now, this gentleman had a cardiac arrest shortly after the EKG was taken, and he ended up getting a stent in his LAD. Okay, so if you're advanced at this, you can see that, yes, you saw that coming because he had a biphasic T wave in V3, and he also had a T wave inversion here, and also V1, because V1 through V4 are all fed by the LAD. They're all contiguous leads. That's the term, contiguous, okay? Oh, hey, Rena, you can't find the Zoom. That's okay. This is perfectly fine as well. Okay, so when I'm teaching you the basic stuff and you're like shaking your head, why do I need to learn the basic stuff? This is why. Because when you identify quickly there's a problem, hopefully you prevent the cardiac arrest. And you do that with the shape, the direction, and the size of the T waves, as well as any ST segment elevation. So essentially, what is the EKG doing? It's allowing the heart to talk to us. And so it sends a signal to the EKG paper, the electricity does, and we can see from that who's running the heart. When I say who's running the heart, what I mean by that is what part of the conduction. So we'll talk about that tomorrow. We always want the sinus node to be in charge and running the heart, but sometimes it's not. And we need to be able to identify when it is and when it isn't, right? Because the sinus node is like the president of the heart. And then, of course, you also have to understand that despite, my best strategy, which initially coming out of school was, well, computers are smart, so I'm going to just let the computer tell me what's wrong. Now, here's the thing. In this case, it's actually right, okay? But about 6 to 42% of the time, it's wrong. So I like to make the joke that who's inside there doing that reading anyway? I think it's these guys, and clearly they do not know what they are doing. So just like you would not trust them to read your EKG, right? We need to actually read it ourselves. So don't trust the read all the time. So we basically, instead of trusting him or these guys, the minions, we're going to trust ourselves and do our own EKG interpretation. So we are like the interpreter for the heart, okay? And computers are just as smart as the programmers, right? Exactly. And so we always have a joke that the plaintiff attorney programs the software of the EKG machines, but I think that's probably true. Now let's go back to foundations for a second, and let's talk about the 10,000 foot view of what the heart is doing back there. So if you think about it, you see this house here, and this house has plumbing, so does our heart. And the plumbing is the vessels. And then you have the electricity, which is the power outlets, right? Which is the conduction of the heart. We have the walls of the house, which are the muscle, right? Walls of the heart. And then the valves are the doors, okay? And they either open or shut completely or they don't. If they don't shut completely, it's regurgitation. If they don't open, it's stenosis. And so I really just think that when you have a patient who's wondering why you're doing so many tests, this is a great analogy that people can get behind, because you're not going to catch everything on just one test, right? If that was true, we would just do an EKG. But since we can't always trust the EKG, we need more data, stress tests, echoes, etc., and sometimes Holter monitors. Now, a concept check. Here's the heart sending out its electricity to the chest wall to be read on the tracing, right? And so if they have a really big R wave, we know there's probably a lot of muscle underneath there. If it's small, then it's unfortunately we're worried about other things. Some of them are bad, most of them are not. But the worst case scenario is that we could have either some ACS or even a pericardial effusion. So the size matters, okay? And this is an example of what low voltage would look like, that small R wave. And you can see here that like basically there's almost flat here. That's not good. And your P wave, which is the mom of the family, and the dad, the QRS, and the baby T, they should not all be the same size. And so there is very little activity going on here, very abnormal. And this patient did have a pericardial effusion because something was getting in the way. This fluid between the sac and the heart was impeding the EKG getting the signal to read out for us. So that's the thing we worry about the most. But essentially, we also have to understand who's back there doing the talking. So, talking about the conduction system, this is the sinus node, okay, who should run the heart. Sinus node runs the heart at about 60 to 100 beats per minute. It sends the impulse down to the AV node, and then we send the impulse down at the same time to the bundles. Does anybody know for bonus points what these little guys are called? These little itty bitties. What are these guys called? And also for bonus points, what happens here at the AV node? What happens here at the AV node when the impulse goes down? So let's see if I have any guesses. Yes, Purkinje, Marcia, that's your your cardiac and you coming out. Love it. Yes, Purkinje, Joe. Yes. So basically, when you have the sinus node firing, what wave will you see when the sinus node is in charge? So the sinus node makes what wave? The P wave. Good job, KJ. Okay, so we always want to see a P wave. Let's see if we see one on here. Oh, yes, we do. Here's one right here, and hard to see in a lot of other leads. You can see one in lead 2. So yes, we do have a sinus rhythm. Okay, now let's talk about the waves. So I want to see in the chat, I'm going to keep my chat open. I'm going to point to a wave and I want you guys to tell me what it is. Okay, what wave is this here? Oh, I see that Rena also got Purkinje. P waves, good. What about this one here, guys? This one is anyone? We have the P here, the Q. Marcia, thank you. What about this one? R wave. This one? S wave, good job. This one is the P wave. And lastly, this one is the U wave. Perfect. You guys got them all. I don't know if you need this class. This may be too basic for you, but wait, it's not because there's a few things you may not have known. So first of all, the P wave, it shouldn't be notched. If it's notched, a lot of times that means there's left atrial enlargement, and that can be a precipitator or an indicator that AFib is going to happen at some point. It shouldn't be too tall either. If it is, a lot of times that means there's right atrial enlargement. So you definitely want it to not be too close, too needy. You don't want it to be notched. Now the QRS, we don't want it too tall. We don't want it too small. We worry on both ends of the spectrum. So it's kind of like the Goldilocks story when the Goldilocks was looking for the porridge, making sure it's not too hot. That was a long time ago. Maybe some people don't know that story. And then the T wave should be upright. It shouldn't be too pointy. It shouldn't be too big. And it shouldn't be inverted except for the 2 leads, AVR and V1. And then, of course, you shouldn't have a U wave. A lot of times that's a sign of an electrolyte abnormality. So here's a beautiful P wave. This is what they want to look like. We want them to be smooth and beautiful and round. We want them to be within the 200 milliseconds next to the R wave here. If it's more than that, we got to think about something called a first degree heart block, which is usually benign. Actually, even though it sounds awful, usually benign. It's not the reason the patient's having the syncope. And then the QRS, we are very closely watching this to see how wide it is. We don't want it to be more than 3 small boxes or 120 milliseconds. If it's wider than that, we're start thinking about things like heart blocks, okay? And I'm seeing you on Facebook too, you guys. You guys are nailing it. And then, so if it's wide, we think about bundle branch blocks, but also things like hyperkalemia. Now, thinking about terms for a second, there's something dangerous that can happen sometimes, and it has to do with the T wave. So we already told you the shape, the size, the direction matters, but also there's part of this T wave that's vulnerable. This is called the relative refractory period. And just to give you some framework, we always worry about the QT, right? The the QT interval, and how long that is. The reason why we worry about that is because if there's a longer QT, there's more vulnerable room in the T wave. And for an R on T phenomenon to happen, for an R wave to come on the last part of the T and send someone into torsades de pointe, which is lethal. So knowing that that can happen, we don't want those long QTs. We want them under 460 ideally, in females, and under 450 in a man, but not too short either. We want them just right, the Goldilocks T waves. Now, talking about waves, there's Q waves. I call it the Q wave conundrum because everybody gets kind of confused on the Q wave. So I'm going to attempt to kind of put it in a framework that'll make sense to you. So first things first, you have to know that it's important to be able to measure, okay? So this is going all the way down the R wave. And then if you cut it in thirds, you can see that this Q wave is a third the height of the R wave and therefore pathologic. Okay. If it's smaller than that, it's probably not an issue. Some textbooks say a quarter, some textbooks say a third. I would err on the side of a quarter. But if they're, deep, then they're probably old infarction, but could be new infarction. There's also other things that could mean that we don't have time to go into, but usually it's old infarction, usually. Also, if it's wide, those are the two times that we're worried about Q waves. There's actually more, but as far as ischemia, those are the two times. Now, here's what they look like in real life. You can see right here that there's a nice 1/3, the height of the R wave here, right? A tiny little one in F and a tiny little one in 2. But this is just telling us that we have contiguous leads with Q waves, which means touching, which means fed by the same artery, in this case, the right coronary artery. But this is a third the height, and so it meets criteria, which is why the machine is saying possible inferior infarct age undetermined. So normally we've learned that the Q wave means scar, but it can happen within an hour of an MI, which is why the machine so sneakily says that I do not know when this Q wave came. You can do clinical correlation, right? Which is our job. So we'd look at old EKGs. We'd also, if they had symptoms, we would worry about it. Okay. So there is a couple T waves that you want to just spot by looking at them. This one is the first one. This T wave is normal. It is a little bit asymmetric. This T wave is big. There's some ST segment making the T wave look big. So ST segment elevation. So in order to determine what's going on with him, we would need a 12 lead to see if he has any other ST segment elevations, right? This one you see all the time when you have a big ventricle. This is a change associated with what's called left ventricular hypertrophy, okay? It's called a repolarization abnormality. It's not ischemia. This one is pointed and tall. So what do you think is going on here? And then tell me what you think is going on here. It's the opposite of this. Because very tall, very small. There's something wrong. And excellent, Chelsea. Chelsea for the win. Yes. Hyperkalemia. Good job. And this would be hypo. Both are probably going to stay in the hospital, right? And then, okay. So let's talk about the T waves. The T waves are on this EKG. Are they following the rules? Are they following the rules? We've got T-wave inversion, T-wave inversion. Oh my gosh, these T-waves are behaving badly, right? Very, very bad. These guys are upright. These guys are inverted and symmetric, another term we really need to quantify, symmetric, so they're not following the rules. Because remember, they're supposed to be upright in all the leads except for ABR and V1. So these ones are not following the rules, which is concerning for ischemia. These are concerning for ischemia as well. But sometimes you'll see them in other states like cardiomyopathy. So this patient did have a cardiomyopathy. So there's not just one reason for the T waves to be upside down. Okay. But this was an EKG that's like basically almost opposite of what you should see. And just going and pointing out right here too that the T wave is very peaked. It's not smooth. So we're worried about because it's bigger than it should be, and because it's not, we're worried about the atrium being enlarged. So just an example to show you of that, which is kind of cool. And all these T waves are behaving badly. Now you've got the R to R interval, which is something we're going to use tomorrow. And this is looking at the regularity between the R waves. And on an EKG, a rhythm strip, you're looking to have regular intervals. And if you don't, you could potentially be dealing with something like AFib. So we'll be showing you rhythms like that tomorrow, but know the R to R interval, that's what we're using. And then now let's go back and revisit the segments and try to identify them. So if you could type in the chat for me, you guys, what you think of what's going on here. Okay, so this segment is the what segment? Yes, KJ already knows. PR. Good job, Angela. This one here, this one is the QRS. Good job. This segment, the most important one on the whole EKG. Good job, Cindy. Crystal, yes. ST segment. And this one here is the one that should be less than 460. Good, Crystal. Okay, awesome. So that's pretty easy. Now, here's the thing, guys. Oh, hey, Carla, what's up? So here's the thing. I'm going to tell you that as much as I love normally my intervals, I trust this part of the EKG. I don't really trust this part, but I normally trust this part. In this case, these are also leading us astray because, thank you, KJ. The saying the QTC is 713. Okay, QTC 713. And that would be very long. It shouldn't be over 460. But when you have artifact, it'll falsely make it look long. So what you need to do is you need to get another one and it'll show you the real QT. Okay, so don't be falsely fooled. You can see here when it is no artifact, it correctly calculates it at 444. So we were actually fine. No reason to worry there. So they do matter, and Remy wants to tell you about why they matter. So this was a case of a 51-year-old female who felt general weakness, which is why she called the ambulance. She felt like the water ran out of her. She was under a lot of stress, and she had a lot of neck pain, so she was on methadone, and she had a lot of psych medication she was on, in addition to hypertension in her history. And that day she drank some alcohol and did some cocaine and then called 911. She didn't feel good. So she actually went into Torsades for the ambulance. They ended up shocking her once, 200 joules, got pulses back, and this was her door time EKG. So what do you think? Is it a STEMI, or is there something else potentially going on? So I'm going to say we don't have the complete intervals here, but Crystal noted, and I'm going to show you what Crystal was looking at. Crystal, strong work, noted there was a prolonged QT. Okay, so what you can do if you don't have the intervals, and I specifically took it off, it was actually 512, which is too long. You go from the R to R, you march all the way back, and then you draw halfway down the line, okay? So when you do that, when you draw halfway and your T wave is right halfway between, that's an eyeball way to know that it is at least 500, okay? And she did have cardiac arrest because of prolonged QT, and it turned out that the methadone was definitely not helping, okay? Methadone could be a QT prolonger, along with, honestly, a lot of other things. There's just no free lunch when it comes to medications. They all have side effects. When she got off all her QT prolonging medications, and she was on multiple, her QT came back down to a nice range. And so we kept her off the medications. that were QT prolonging and switched her to anything else, which was a happy ending for her. So can you see the power in learning these more fine point details and really just getting a good basic review? This is me feeling like I was at the top of the king of the mountain here, or queen of the mountain, because when I started learning this stuff, I was like, oh, I feel like I can conquer anything. So tell me in the chat, what are you so far most excited about? And if you had a chance to get your workbook, we're going to go through that. So hopefully you guys have your workbook ready and printed. I put a link in the Zoom feed, and I think Ruben put one in our Facebook feed. So you should have an access to it. But we're going to basically go over the workbook in a minute. But I wanted to give you a sneak peek of what to get ready for tomorrow, because tomorrow is going to be rhythm day. We're going to do the atrial rhythms, the ventricular rhythms, a little bit on the junction, and we're going to get you feeling like you have a system to attack those as well. And here's the 3 questions you'll be asking: fast versus slow, wide versus narrow, regular versus irregular. And that is going to help you solve the case the majority of the time. We're also going to be hunting for the P waves, and you can see there definitely is a P wave here. I'm also going to show you that lead 2 is probably your best place to look for the rhythm. That will usually tell you if you have a P wave, and it'll be super helpful. So let's grab your workbook and let's run through day 1. Yes, KJ says sinus makes P. So here we go. P wave is a small deflection. It represents what part of the heart is contracting. What part of the heart is contracting? And this would be the atrium. Okay. The Q wave is initially the negative. See how it goes down? Negative deflection. It is normal if it is less than 1/3 the height of the R wave. So you can fill that in if you want. The QRS represents the ventricles depolarizing. Okay, ventricles. I'm loving. Yes, thank you. Thank you for putting it in, KJ. And if you have, after your P wave, a first negative deflection, that's a Q wave, okay? So depolarization of the ventricles, this is the first positive deflection. T waves should be a little asymmetric, and they should be upright in all leads except for AVR and V1, okay? Let's run through these 2. These are really easy. So the U wave, we talked about that. What wave does that come after? The U wave. It comes after, well, first of all, it shouldn't be there, right? But if it's there, it's coming after the T. Good job, Chelsea and KJ. And it could be due to what kalemia? Is it hyper or hypo? Hyper or hypo, usually. It's usually hypo. Yeah, good. And then a delta wave, it's a slurred, you have a slurred upstroke in the QRS, and it often comes with, we didn't talk about this, we'll talk about it more tomorrow, a short PR interval. So you'll see that with the Wolff Parkinson's White patients, or WPW as KJ put. And the thing about this is that's one of the reasons we look at the PR interval, because you're looking at the beginning of the P to the beginning of the R. And it should be between what number and what number? Does anybody know the intervals? Between 120 and 200 milliseconds. Good job, Crystal. And then basically the distance to the PR segment, we're measuring from the P wave to the R. We talked about that. And we're looking in the ST segment for both elevation and depression. Thank you, KJ, for putting that in there a different way. And there's reasons for ST depression to happen. So let's talk about those. And we're going to look for those on night 3 in the 12-week class. So if you have basically cardiac ischemia can cause it. ST depression can happen from hypokalemia. And there's a medication that starts with a D that can also cause some ST depression, more of a scooping. Does anybody want to type that? Oh, look at you, Didge. Yes, Marcia, Crystal, you guys are all over it. I'm super, super pumped. Okay. And then a long QT, what did we say that could lead to? We talked about this already. You guys should have this fresh on your mind. Yeah, good job. Right, KJ. Torsades. Exactly. a lethal arrhythmia. And then the R to R is the distance between the QRS complexes. We can see if a rhythm is regular or irregular. Now, if I went too fast for you and you wanted to review the answers, they are in the day one guide in the Facebook group. They are right there just waiting for you already. And a big thank you, guys, for coming to show up today. I hope you had fun. Yes, it looks like we have a question. If we have a question, please tell me because I'm about to announce our prize winner. Yeah, type in the chat if you have a question. And I'm going to talk to you about the prize for tonight. Yes, thank you so much. Okay, so check it out, you guys. We're going to do a random drawing tomorrow night based on you guys being live. It's going to be only given to one of you guys who are live, either on Facebook or Zoom. Hey, Janice. You're going to have a chance to win this. Now, this is the EKG workshop kit. It's a box that I just put together, a fresh box, so I haven't even sealed it yet. And if you want to win this, let me show you what's in it. Okay. So first of all, what you have in it is a little mini painting. Okay. So I paint these, I paint the easels. And right now I'm into this, this color scheme. And I usually put a little word on them to, just, yeah, make you have something happy on your desk. Okay. So whoever wins this box is getting this little mini painting. You also get this wonderful tool called the RCAT window. These are on Amazon for $14, I believe. And this gives you a way to check heart rate. It gives you this red line here, so you can look for ST elevation. It also tells you STEMI criteria on the back. So this is coming to you. You're also getting a set of crayons with a red, green, and blue crayon inside. Super cute, because we want you to have the right colors to color in the contiguous leads on your EKG that we send you in here. So you actually get a whole workbook full of real EKGs to practice on what you've learned in our challenge. We actually go through these, though, together live in our 30-day EKG challenge, but you can use them without joining by just using them to practice. They're not textbook. They're actually real EKGs with artifact and everything. And this is the EKG that we send you to practice on, okay? And you can look at the intervals and see if they're normal. You can color code the EKG with your new crayons. And then I give you a cheat sheet with all the axis stuff on here. And then I give you the instruction sheet on how to use your tool that you win. And I will send one of these kits. These are normally sent to anybody who purchases our 30-day EKG challenge because we use all of these in the workshop that we do in there. But I'm going to send one of these out to a winner. Now, how can you win? Well, all you have to do is type in 30-day into the chat, either in Zoom or Facebook, and I'll be selecting a winner to mail this out to tomorrow, and I'll announce it. So we love to give away prizes. We're going to give away prizes every night. Got you. I see you. And we'll be announcing the winner tomorrow. So we did good tonight. We didn't go too long. Tomorrow will be about the same amount of time. We're not going to keep you too late. So let us know in the meantime if you have any questions. Now, one question that comes up commonly is, do we record these sessions? Yes, we do. And then we put a replay link together so they're off Facebook, but we also put them in the guide section. Now, I see that Coach Michelle is here, and I've been missing her. I'm going to see if we can. Are you able to come on camera, Michelle, so you can say hi to everybody? Because I want you guys to meet Michelle. She's our lead coach in our 30-day EKG challenge. And sometimes she even does a game for us. Let's see. Michelle, I don't think I'm able to promote you for some reason, Michelle. But anyway, maybe Michelle will show up for us tomorrow. If you guys have any questions in the meantime, don't hesitate to ask. And we'll see you guys tomorrow. We're going to be a little earlier tomorrow. We're going to be earlier. So basically, we're doing one session this time. So our East Coast folks don't have to stay up too late. But then the last night will be the regular 5:30 PST time. So let me know if you have questions. We'll see you soon. I'll announce the prize tomorrow. Have a great night, you guys. Bye.